we'll be breaking down all major concepts covered on the exam. So imagine drawing blood from a patient, right? But instead of a smooth, easy flow, the blood is just, it's so abnormally thick and sludgy that it barely even moves through the syringe.
Yeah, it's like trying to draw up syrup.
Exactly. You are basically staring at a massive physiological traffic jam. And today, we are doing a deep dive into the bone marrow to find out, exactly why that happens.
Right.
As your MCCQE reviewers, our mission is to help you, the Canadian medical student, feel entirely comfortable navigating the complex mechanisms of the S06 hematology objectives. Specifically, we are exploring the pathophysiology, the presentations, and the management of myeloproliferative neoplasms.
Or MPNs for
Right.
short. And to do that, we are drawing directly from reliable StatPearls articles to map out how, like, a single rogue stem cell can completely change the consistency of patients' blood.
Yeah, it's wild.
We'll trace these diseases all the way from the genetic origins down to their really dangerous clinical complications.
Absolutely. But before we step onto the factory floor of the bone marrow, we do need to make a quick note that this deep dive is strictly for medical education purposes, to help you understand the clinical reasoning for your exam.
Right, is not medical advice.
Yeah, not medical advice. All clinical decisions in the real world should always involve a qualified healthcare provider.
Definitely. So let's start by looking at how the bone marrow normally operates.
The factory floor.
Right, the factory floor. You have these hematopoietic pluripotent stem cells, and they act as the master regulators. They have this amazing self-renewal capability, and they carefully direct the production lines, either the myeloid lineage or the lymphoid lineage.
And they're not just guessing, right? Like, they respond to a very strict set of instructions.
Exactly. They get cues from the marrow environment and specific growth factors to churn out the exact right amount of red blood cells, granulocytes, and megakaryocytes. It's a beautifully balanced supply and demand system.
Well, until the regulation completely fails.
Right.
Because in MPNs, those master stem cells undergo a clonal mutation. They essentially go rogue, they ignore all the body's stop signals, and they just hold down the print button on the myeloid assembly line.
Yeah, they just bypass the whole feedback loop.
So you end up with an unchecked overproduction of one or more mature functional blood cell lines, and they all just go pouring out into the peripheral blood.
And, the World Health Organization identifies 4 classic types of these unregulated states. We often call them the core 4 MPNs.
The big ones you need to know for the boards.
Right. You have chronic myeloleukemia, polycythemia vera, essential thrombocythemia, and primary myelofibrosis.
Okay. I mean, there are a few really rare variants in the WHO classification too, right?
There are, yeah.
Yeah.
But honestly, these core 4 are the ones that dominate clinical practice and, more importantly for you, the board examinations.
Okay, let's unpack this. If a patient walks in with wildly high blood counts, an enlarged spleen, and fatigue, where do we even begin? Like, how do we sort out which of the 4 it actually is?
That's the main challenge.
Is there, like, one definitive test that splits the field early on?
Broadly speaking, yes.
Yeah.
The very first branch point in your diagnostic algorithm, and you should highlight this in your notes, is checking the BCR-ABL1 genetic status.
Ah, okay, the BCR-ABL1.
Yeah, this single genetic marker divides our core 4 into 2 distinct camps. Out of the classic MPNs, chronic myeloid leukemia CML is the sole BCR-ABL1 positive neoplasm.
Wait, really? The only one?
The only one of the classic 4. The other 3 are all BCR-ABL1 negative. So finding that mutation isolates CML entirely.
Okay, so I remember from med school, the cytogenetics of CML involve the Philadelphia chromosome, right? That's a reciprocal translocation between chromosomes 9 and 22.
You got it, the T922 translocation.
But why does physically swapping a piece of a chromosome actually cause a cancer? Like, how does a mechanical genetic change lead to a runaway bone marrow?
It all comes down to the fusion of 2 specific genes. So you have the BCR gene on chromosome 22, and then the ABL oncogene on chromosome 9. When those 2 are spliced together by the translocation, they create the BCR-ABL1 fusion gene. And this new, totally unnatural gene encodes a chimeric protein with massive tyrosine kinase activity.
Right, tyrosine kinases. Those are basically enzymes that act as, like, on-off switches for cellular functions, right?
Exactly. And this specific fusion protein is a switch that is permanently glued in the on position.
Oh, wow.
Yeah, it is constantly signaling the myeloid cells to proliferate completely, regardless of what the body actually needs.
So the factory is basically running at maximum capacity 24/7.
Exactly.
Clinically, I mean, a lot of these patients are completely asymptomatic, right? They're just caught on a routine blood test that shows massive leukocytosis.
Yeah, quite often.
But if they do have symptoms, they're usually systemic, like fatigue, weight loss, or early satiety.
Yes, and that early satiety is a huge clinical clue.
Right, because the spleen is working overtime to clear all these excess cells, which leads to massive hepatosplenomegaly. It physically presses up against the stomach.
It does. Just squishes the stomach so they feel full after eating a couple of bites.
But the timeline of CML is what seems most critical for the MCCQE. Like, how do we stage this continuous overproduction?
So the histopathology dictates the phase, and there are three very distinct phases you have to memorize.
Okay, hit me.
First is the chronic phase. The bone marrow is hypercellular, and you see a left shift in maturation in the blood.
Yeah.
But, and this is key, your myeloblasts, which are the highly immature cells, are sitting at less than 10%.
Less than 10%, okay.
Then, unfortunately, the disease progresses to the accelerated phase. Here, myeloblasts range from 10% to 19%. Your basophils also jump up to 20% or higher.
Wow, okay.
Yeah, and the cells start acquiring even more chromosomal abnormalities on top of the Philadelphia chromosome.
Wait, but then there's the blast crisis phase, right, which triggers when myeloblasts hit 20% or greater. I need to clarify something here for everyone listening, because if they hit 20% myeloblasts, isn't that just the formal diagnostic criteria for acute myeloid leukemia? Like, does the disease actually change its entire identity?
It does. It totally transforms. That 20% blast threshold is the absolute line where a chronic functional overproduction transforms into an acute leukemia.
Man, that is terrifying.
It really is. The bone marrow factory has completely lost its ability to mature cells at that point. It's reverted to just making defective, primitive blasts that crowd out everything else.
No more functional cells at all.
Right. And this carries a very poor prognosis. Historically, before modern medicine, this was the tragic, inevitable outcome for CML patients.
And this is the incredible part, knowing the exact mechanism, that permanently on tyrosine kinase switch allowed for one of the greatest triumphs in targeted therapy, right?
Yes. The tyrosine kinase inhibitors, or TKIs.
We can literally use a drug to turn the switch off.
Exactly. Imatinib was the first-generation breakthrough.
Yes.
Physically binds directly to that chimeric protein and shuts the signaling down.
That's brilliant. And now we use second-generation ones too, right?
Yeah, we rely heavily on second-generation TKIs like nilotinib and dasatinib. Clinical trials have shown they are even more effective at achieving deep molecular remission.
So patients in the chronic phase are just started on these immediately.
Immediately. It effectively turns what used to be a fatal disease into a manageable chronic condition.
That is just incredible. But what about stem cell transplants? Are those still used?
They are, but they're now generally reserved for patients who slip into the accelerated phase or blast crisis,
Yes.
or if they fail TKI therapy.
Okay, so that's CML. We know the Philadelphia chromosome creates a runaway enzyme. But what happens if a patient has all the clinical signs of an overactive marrow, but they test negative for BCR-ABL1?
Then we have to look elsewhere.
Right, like what is driving the factory in the other three, polycythemia vera, essential thrombocythemia, and primary myelofibrosis?
In those cases, we look for the restricted driver mutations. These are somatic mutations found in the hematopoietic stem cells that cause the clonal expansion. And the heavy hitter here, the one you absolutely must know for the exam, is the JAK2 mutation.
JAK2, right.
Yeah, this gene codes for Janus kinase, which is a protein kinase involved in the JAK-STAT signaling pathway. The most common mutation is a specific substitution of valine to phenylalanine at codon 617.
Oh, the JAK2V617F mutation.
Exactly. You will see that exact string of letters and numbers on the test.
And just like the BCR-ABL1 fusion, this mutation basically artificially activates the signaling pathway, right?
Got it. The cells are tricked into thinking they are receiving constant growth signals from cytokines, even when they aren't.
But the prevalence across the diseases is what always confuses me. Like JK2 is present in roughly 95% of patients with polycythemia vera.
Almost all of them, yeah.
But it's also found in 50% to 70% of essential thrombocythemia patients and about half of primary myelofibrosis patients. So how does the exact same mutation cause three completely different clinical pictures? I mean, how does the body decide which cell line to overproduce?
That is a fantastic question. It mostly depends on the specific cellular environment, the patient's genetic background, and something called the allele burden.
Allele burden, meaning like what percentage of the patient's alleles actually carry the mutation?
Exactly. A very high JAK2 allele burden strongly drives erythropoiesis, pushing the red cell line, which leads to polycythemia vera.
Oh, okay.
The lower burdens might just push the megakaryocyte line, leading to essential thrombocythemia.
That makes a lot of sense. So if a patient with ET or PMF doesn't have the JAK2 mutation, what do we look for next?
Then we check for CAR, which is the calreticulin gene mutation. That's found in about half of the remaining cases.
Okay, CLR.
Or we look for MPL, which is a mutation in the thrombopoietin receptor itself.
But wait, what if a patient tests negative for all three? Like JAK2, CLR, and MPL are all totally absent. Are we just, out of luck diagnostically?
Not entirely. We call that the triple negative scenario, and it accounts for about 10% to 15% of ET and PMF patients.
Okay.
It doesn't mean they don't have an MPN. It just means the driver mutation is something rare that we haven't routinely started testing for yet.
Right.
But more importantly for the exam, knowing the mutation status reveals the patient's likely trajectory.
Oh, prognostically.
Yes. Patients with the CALR mutation actually tend to have a better overall survival benefit.
Okay, good to know.
Conversely, triple-negative PMF patients have a notably worse prognosis and a much higher risk of leukemic transformation.
Wow, okay. So let's apply all this pathophysiology clinically, starting with polycythemia vera, or PV.
The red cell problem.
Right. Which brings us back to that initial image of incredibly thick, sludgy blood. PV is characterized by a massive overproduction of red blood cell mass.
Yeah, and that hyperviscosity leads directly to severe hypoxia in the tissues and a super high risk of thrombosis.
So these patients present with things like headaches, dizziness, visual disturbances, and a very red facial plethora. Like they just look flushed.
They do. But one of the absolute most fascinating clinical presentations of PV and a huge board buzzword is aquagenic pruritus.
Oh man, this one is crazy.
Patients will describe this intense, unbearable itching, stinging, or burning sensation that happens specifically after taking a warm bath or shower.
I've always wondered about that. Why does water make their skin burn? I mean, it isn't an allergic reaction to the water itself, is it?
No, not at all. It's actually the temperature change. The warm water triggers a massive degranulation of mast cells and basophils.
Oh, and those are also overproduced in the bone marrow of PV patients.
Exactly. So these cells dump massive amounts of histamine and prostaglandins directly into the skin. It causes severe pruritus without any visible rash.
That makes perfect mechanical sense. They have too many basophils, the heat pops them open, and boom, histamine everywhere. So, to diagnose PV, the WHO major criteria are actually pretty strict, right? You need elevated hemoglobin. I think it's greater than 16.5 grams per deciliter in males and 16.0 in females.
Right, the numbers are important.
You also need a bone marrow biopsy showing hypercellularity across all three lines panmyelosis. And you need that JAK2 mutation.
Yes, those are the major criteria.
But I need to stop you here on the minor criterion, because the minor criterion requires a subnormal serum erythropoietin, or EPO, level.
Yes, a low EPO.
But if the bone marrow is massively overproducing red blood cells, shouldn't their EPO levels be sky high? Like, why is a low EPO a diagnostic requirement? That just feels backward to me.
I know, it totally seems counterintuitive until you look at the feedback loop.
Okay, walk me through it.
In PV, the bone marrow is producing red blood cells autonomously, right? It's gone rogue. It does not care about EPO anymore.
Right. The JAK2 mutation is doing all the driving.
Exactly. So because the blood is completely saturated with this massive red cell mass, the kidneys sense that super high oxygen carrying capacity.
Ooh. And the kidneys are the ones that make EPO.
Right. So the kidneys dramatically downregulate their production of EPO to try and stop the factory. They are basically screaming, "We have enough blood." So the EPO drops to rock bottom.
Oh, wow. So the low EPO is actually the body desperately trying to pull the emergency brake on the bone marrow.
Precisely. If you have a patient with massive polycythemia and their EPO is high, you are not looking at PV.
You're looking at a secondary cause.
Exactly. Like chronic hypoxia from severe COPD, sleep apnea, or maybe an EPO-secreting tumor, where the body is intentionally demanding more red blood cells.
Man, understanding that feedback loop is just critical for the exam.
It is the ultimate exam trap.
So for managing PV, the goal is obviously to reduce that hyperviscosity. For low-risk patients under 60 with no history of clots, we use therapeutic phlebotomy, right?
Yes, physically draining the excess cells to maintain a hematocrit of less than 45%.
We also use low-dose aspirin to prevent clots. But high-risk patients get the phlebotomy and aspirin, plus a cytoreductive agent like hydroxyurea to suppress the marrow.
Right. But there is another vital clinical paradox to watch for here with management.
Oh.
Some PV patients actually develop acquired von Willebrand disease.
Wait, really? How does that happen?
The excessively high platelet count, causes the von Willebrand factor multimembranours to just be broken down way too quickly in the blood.
Because they're getting used up or sheared.
Yeah, exactly. And if this happens, you have to immediately stop the aspirin.
Oh, of course. Because even though they have a hyperviscosity disease that causes clots, they now suddenly have a severe bleeding tendency.
Right, and aspirin will trigger a major hemorrhage.
Wow, it's a terrifying tightrope to walk.
It really is.
And we see a similar issue in essential thrombocythemia, or ET, where the factory problem is heavily skewed toward the platelets, right?
Exactly. The diagnostic criteria for ET require a platelet count of 450 times 10 to the ninth per liter or higher.
That is a lot of platelets.
Yeah. And alongside that, a marrow showing enlarged, mature megakaryocytes,
Oh.
but without the left shift we see in CML.
Okay. And clinically, how does ET present?
Well, ET can cause severe vasomotor symptoms. A classic presentation for the exam is erythromelalgia.
Erythromelalgia. That's microvascular occlusions in the distal extremities, right?
Yeah. The excessive platelets basically clump together in the tiny vessels of the hands and feet.
Ouch.
Yeah. It causes a deeply painful burning sensation, intense erythema, and sometimes even localized gangrene if it gets bad enough.
And we manage those microvascular symptoms with low-dose aspirin, mostly.
Yes. And we add hydroxyurea for high-risk patients to bring the platelet count down.
Okay, so we've seen what happens when the factory overproduces red blood cells in PV and when it overproduces platelets in ET.
Right.
But what happens when that relentless overproduction causes so much chronic inflammation that the factory walls literally scar over and shut down completely?
Now you're talking about the defining mechanism of primary myelofibrosis.
EMF.
Yeah. The continuous release of inflammatory cytokines, particularly from those abnormal megakaryocytes, constantly stimulates fibroblasts in the bone marrow.
So the fibroblasts just start laying down scar tissue.
Exactly. Dense reticulin and collagen scar tissue. It effectively turns the marrow into a dried-out, fibrotic sponge.
And the scarring creates one of the most distinct physical exam findings you'll ever be tested on.
Oh, absolutely.
When you try to perform a bone marrow aspirate on a PMF patient, you encounter a dry tap.
Right, the dry tap.
The syringe just pulls back nothing but a vacuum because the liquid marrow has been entirely replaced by dense collagen.
It's just solid tissue at that point.
Yeah.
And, if the primary factory is boarded up with scar tissue, the body still desperately needs blood, right?
Right.
So hematopoiesis is forced to relocate to extramedullary sites.
Extramedullary, meaning outside the marrow. Back to the organs that produced blood during fetal development.
Exactly. The spleen and the liver basically have to come out of retirement and take over the job.
Which results in massive hepatosplenomegaly.
Yes, massive.
Mm.
The spleen can become so incredibly enlarged that it physically crosses the midline of the abdomen.
That is insane. I always found the peripheral blood smear for PMF fascinating, too, because it shows the physical toll of this whole process.
Oh, the teardrop cells.
Yes. You see a leukoerythroblastic picture, but the absolute standout feature is the teardrop-shaped red blood cells, or dacrocytes.
You really have to imagine these poor, rigid red blood cells physically trying to squeeze their way out of the heavily fibrotic scar tissue in the marrow.
It's like they get completely deformed and literally pinched into a teardrop shape as they escape into the circulation.
It's a great visual for the exam.
So how do we even treat PMF?
Well, treatment for PMF focuses heavily on symptom relief. Ruxolitinib is a big one.
That's a targeted JAK inhibitor, right?
It is, and it's remarkably effective at shrinking that massive spleen volume and reducing all those systemic inflammatory symptoms.
That's not a cure.
No, unfortunately. The only true potential cure for high-risk patients remains an allogeneic hematopoietic cell transplant, basically replacing the mutated stem cells entirely.
Wow. So as we look across all four of these MPNs, it really seems like no matter which specific lineage is overproducing, the patient is walking a constant tightrope between throwing a massive clot and having a major hemorrhage.
That is the perfect way to summarize it. Thrombosis and bleeding are the unifying acute dangers across the board, driven by abnormal platelet function and altered hemodynamics.
But there's a chronic danger too, isn't there?
There is. The chronic looming threat is transformation.
Right.
Just as CML can transform into a blast crisis, PV and PMF carry this constant risk of mutating further into myelodysplastic syndrome or straight into acute myeloid leukemia.
And when that transformation occurs, the abnormal cells just completely overwhelm the system and the prognosis drops drastically.
It does. It's what we are constantly trying to prevent or delay.
Man, okay. Synthesizing this for the clinical scenarios you'll face on the MCCQE. always look for the BCR-ABL1 status first to isolate CML, right?
Absolutely, step one.
And remember the mechanism of those tyrosine kinase inhibitors for CML. For the others, trace the JAK2 pathway. Remember the hyperviscosity and low EPO feedback loop of polycythemia vera? Don't get trapped by that low EPO.
Definitely don't fall for that.
And finally, visualize the fibrotic scarring and those teardrop cells of primary myelofibrosis.
So we have spent a lot of time today discussing the genetic mutations driving these neoplasms, but, the initial trigger for those mutations remains largely elusive.
Yeah, like why do the stem cells go rogue in the first place?
Exactly. But our StatPearls sources know something really interesting. Exposure to high levels of ionizing radiation and environmental toxins, specifically benzene, are actually documented risk factors for developing MPNs.
Right, because they physically disrupt the genetic integrity of those hematopoietic stem cells, which introduces those somatic mutations over time.
Which raises an incredible question for the future of hematology.
Oh.
Think about it. As our global occupational safety standards evolve, but our daily exposure to complex environmental toxins, microplastics, and new industrial chemicals shifts.
Oh, wow.
How might the epidemiology of these diseases change? Over the next 20 or 30 years of your clinical careers, will we see the prevalence of the JAK2 mutation fade, only to be replaced by entirely new, unrestricted driver mutations adapting to a changing environmental landscape?
That is a wild thought. It's a reminder that the human body and the diseases that afflict it are constantly reacting to the world around us.
Exactly. The factory floor is never truly static.
Never. Well, we wish you the absolute best of luck with your exam preparations, and we will see you on the next deep dive.